Hello, my friends. Jill Osborne from the IC Network. It is time for another live support group meeting. However, Facebook is being funky. And it doesn't look like I'm going to be able to start a meeting. Give me a quick sec for those of you who are on YouTube, all right? So, what has happened here? Facebook has changed their controls. And now my live has been switched to a channel. What am I supposed to do with that? It's not a reel. It's not a photo or video. Well, we'll try this. I have no idea what this is. Hi, you guys. Okay, that doesn't help me at all. What the hell did Facebook do? Hi, Angel. Oh, Angel, that's great. Her doctor says, thank you. Thanks for helping me out. So, what on earth is going on here? That's very strange. Well, let's do this. Facebook is not, let's see. Hi, Yamo. Let me just give them the link. Well, isn't that freaking awful? Well, it is. That's all I got. That's all I got here. I have no idea what's happening with Facebook right now. So it is what it is. All right, you guys. So we're going to have lots of people watching this meeting as compared to being here live. And that's okay. So my name is Jill Osborne. I'm the president and founder of the Interstitial Cystitis Network. Normally every week I try to do a live support group meeting. It's an international meeting. We have patients here in the United States who watch, along with Europe, Australia, New Zealand, South Africa, Asia, etc. And my job here is to give you the latest news and information because I want you to feel strong, informed, educated. Hello, Joni from Canada. Nice to see you, hon. Hello, Cardsi. Nice to see you too. So again, when trying to set up this meeting, Facebook is not cooperating as is they occasionally do. So that's okay. We're just streaming live on YouTube. Normally when I do these meetings, I like to do and actually here, let me just go ahead and start recording that. Okay. All right. Normally when I do these meetings, I usually do kind of a 30-minute intro because I just kind of want to see, I want you to hear some really good, solid information. My goal is to open some doors, open some windows, give you new information, and then hopefully encourage you to learn more about that information, then go right back to your doctor to ask more questions about it. Now, here's the issue. Doctors don't like it when you hear things on the internet. It's like, Who are you listening to on the internet? Are they a doctor? Yada, yada, yada. And they have every right to be skeptical of a lot of the information you read online because a lot of that information is really quite bad. um, um, my information is quite a bit different though because I'm bringing you information directly from the American Urology Association. And every year, their annual meeting is where the top IC research is shared. And it's also where doctors, urologists, and urogynecologists come to learn the latest information about IC. And so this morning, very, very early this morning, they had their course on IC. And I just want to go through quite a bit of the information that they shared. But we're going to be doing a lot more later this month, too, because our new hot researcher that I think is destined to win a Nobel Prize eventually is Dr. Ann Ackerman, and she was one of the speakers. Angel said, I chose to get surgery instead of the catheter for the rest of my life. I'm about to start pelvic floor therapy after surgery. Pelvic floor therapy works, and I'm going to explain why it works. All right. So anyway, this morning we had the class called Emerging Concepts in IC-BPS. It was taught by Dr. Henry Lai, Dr. Quentin Clemens, and Dr. Ann Ackerman. And because it's copyrighted, I really can't show you the slides. So what I'm going to do is I'm going to read you some of the slides, and they're very, very meaningful for you, especially those of you who are newly diagnosed. So understand here, we got to put this in context. 20 years ago, 30 years ago, doctors around the world were very random in how they treated IC. Some doctors said that IC wasn't real. Other doctors said that it was incurable. Other doctors said, hey, we'll take out your bladder. Other doctors did neuromodulation. It was random as heck. It was just way, way, way too random. And so our American Urology Association put together a panel of experts to review all the research and put together a cohesive set of guidelines that was logical, informed, that would help normalize how IC is treated, to help make sure that doctors around the country were being consistent, that they were paying attention to what they considered to be urgent issues, that they were providing balanced care as instead of very, very narrow focused care. And so we have had guidelines since 2011. The guidelines were revised in 2014, and the guidelines were again revised in 2022. Now, the guidelines are set out in statements. There are basically a couple dozen statements that they want doctors to follow and patients to follow as you are considering treatment. And they're good guidelines. They're compassionate guidelines. They understand the challenges that IC patients face. They understand the treatment challenges that doctors face. They understand pain and why pain needs to be treated. They're good guidelines. And I'm currently sitting on another guidelines committee right now for male pelvic pain. And so these guidelines are grounded in the life of the patient. They're grounded in wanting to make sure that you get the best care you can get, and that we're doing treatments that have a chance to be effective, and we're doing treatments that have a chance to give you back your quality of life and get you back to living your normal life. So I'm going to share Dr. Henry Lai's presentation and also part of Dr. Ann Ackerman's presentation. So again, the guidelines are in a series of statements. Now, the first 4 statements are just very general statements about, let me see here. Guideline statement number 1, the basic assessment should include a careful history, physical examination, and lab examination of that patient to exclude other disorders which can cause these symptoms. Because hello, if you got a UTI, we got to treat your UTI. We don't want to just say everybody has IC when there might have something that's very, very treatable, like an infection. They suggest that urine cultures be done. Even in patients who have an early negative urinalysis, they want a culture done to see if anything grows. And they certainly want any blood in the urine to be worked up to make sure that there isn't any presence of bladder cancer. Now, the IC and cancer are certainly not related in any way. However, if you have symptoms of frequency urgency pain and you have blood in your urine and you were a cancer patient, I mean, a smoker, you were a cigarette smoker, it's that significant tobacco exposure which is associated with the greatest risk of cancer. Okay, guideline statement number 2, we want to make sure that we know what your symptoms are and what your pain levels are, because if we don't know what those symptoms are now, how are we going to know if the treatments work? So they're going to ask you to do a quick voiding diary, and they're going to want to know what your pain level is, because we got to have a starting point, we got to have an ending point. And they basically say that you could just do a 1-day voiding log. So the whole goal here is that for patients with a more aggressive bladder disease process or a pain process, you're not going to be able to hold a lot of urine, or you might be able to hold a lot of urine, but you're peeing all the time, like literally every 15 minutes. Even with a very small quantity of urine in your bladder, you feel the need to urinate. And they can see that in a voiding diary, because if you're peeing every 15 minutes or every 30 minutes, and you don't have a lot of volume in there, then that tells us that we're dealing with a bladder wall issue and or a nerve issue. So getting that voiding log is important. We don't need to talk about that. We don't need to talk about that. I don't need to talk about that stuff today. Okay, so let's get to the treatment information. So concept number 5, guideline statement number 5 is a real distinct change, because it's all based on shared decision making. AUA believes that you have to understand the risks of your treatment so that you can make the best decision for your unique case. So they want doctors to really be educating patients about the pros and cons of various treatments. And they want you, the patient, me, the patient, to really be the key decision maker in what we're choosing to do. They also say, except for patients with Hunner's lesions, initial treatment should be non-surgical. Guideline statement number 6. Treatment response needs to be reassessed frequently. We don't want you to keep doing treatments that don't work. It's a waste of money. It's a waste of time. And it's depriving you and your doctor of an opportunity to take a step back and revisit the diagnosis. So they say the efficacy of a treatment should be reassessed and ineffective treatment should be stopped. Hello, Jennifer. Nice to see you, hon. For those of you who are joining, Facebook is down. We cannot stream on Facebook right now. Guideline statement number 7, multimodal pain management approaches should be used. So this is something that surprises a lot of people. Our guidelines are very compassionate to the pain patient. Extremely compassionate. They want pain assessed at every single appointment, and they want pain treated. So how are we going to treat it? We're going to treat it pharmacologically with various medication, from a stress management standpoint, because when you're under stress, your pain is always going to be intensified. Manual therapy if your pain is from tight pelvic floor muscles, and we want to work with those tight pelvic floor muscles. So they recommend a multidisciplinary approach to the treatment of pain, and they want pain assessed. Guideline statement number 8, the IC diagnosis should be reconsidered if no improvement occurs after multiple treatment approaches. If you're not responding to treatment, do you really have IC, or is there something beyond your bladder that could be triggering your symptoms? Like, for example, a fibroid tumor pushing on your bladder, endometriosis attached to your bladder, a Tarlov cyst in your lower spine. Is there any chance that you have ketamine cystitis? Something if you've gone through chemotherapy, things like that. Hello, Anne. Nice to see you, hon. So if you're not getting better on bladder treatments, we have to ask why. Maybe it's not your bladder. Maybe it's something beyond your bladder, like tight pelvic floor muscles. So, what are some of the conditions that they need to rule out? This is a really interesting list. So, number one, cancer. If you were a big smoker, we want to check that out. If you have a lot of blood in your urine, they want to check that out. They want to rule out infection, and this includes chlamydia, mycoplasma, corynebacterium, mycobacterium, herpes simplex, and human papillomavirus. Okay, your bladder can be infected with viruses. Your bladder can be infected with funguses like candida. We want to make sure that your bladder is not being irritated by chemotherapy. We want to make sure that you don't have bladder stones and things like that. Some of the other things that they're going to rule out are a diverticulum, endometriosis, vaginal yeast infection, overactive bladder, benign prostate obstruction for men, chronic bacterial prostatitis in men, chronic non-bacterial prostatitis, pudendal nerve entrapment, et cetera, et cetera, et cetera. So at that first appointment, understand that you are an anatomical mystery to be solved, and what they're trying to do is understand what's driving these symptoms. It might feel like a bladder infection. You have to know that the bladder is only wired to give you those symptoms: frequency, urgency, pressure, pain. So it's going to feel like a UTI, but it could actually be a bullet wound, a stab wound. Tight pelvic floor muscles. Lots of things can trigger the symptoms in your bladder. Let's see here. So there are many potential treatment options for IC. We've certainly got behavioral things that you can do, like diet management. We've got a lot of oral medications that you can do, like amitriptyline or hydroxyzine. We've got a lot of bladder installations that they can do. There are procedures that they can do, like Botox, neuromodulation. They can do major surgery, obviously, as a last resort. But how do you find the right treatment? And so they have this hysterical slide of a doctor with his hands over his eyes trying to throw a dart in a dartboard. Like, how do I find the right one? How do I find the right one? And as they say right here, treatment should be tailored based upon that patient's phenotype. We have to take a moment to try to understand the underlying cause of your pain so that we can treat it effectively rather than what I call chasing the symptoms of IC. We could chase the symptoms of IC for decades. It's not going to get you better. If you've been on bladder treatments for 20, 30 years and you're not better, and you're still struggling with flares, it's time to ask why. What could we have missed? So as they say here in this fabulous slide, patients who have high tone pelvic floor muscles, tight pelvic floor muscles, need pelvic floor physical therapy. Patients who have Hunner's lesions need Hunner's lesion therapy. Patients who respond to an anesthetic in their bladder, or they have pain on bladder fill that gets better when they urinate, they might do better using bladder installation therapies. And then for those of us who have multiple pain conditions, we have the IC, the IBS, the vulvodynia, the TMJ, et cetera. That's what we call widespread pain. And we're going to be using very different treatments for widespread pain, such as tricyclic, low-dose antidepressants, which act to calm nerves down, gabapentinoids, a variety of other things. Even cognitive behavioral therapy that can help get that brain out of fight or flight is important, because now we know that widespread pain patients, that their brain literally is stuck in fight or flight, and that's intensifying everything. We've got to get that brain out of fight or flight. And the way that we do that is with cognitive behavioral therapy and some of the techniques that I've used in many of these meetings. And just so you know, I'm in this group. I'm absolutely in this group. And I'm not offended when somebody says, hey, let's do some cognitive behavioral therapy. Why? Because I know that I am a childhood adverse event victim, that I was traumatized intensely when I was in my childhood. And that is often the foundation for somebody who struggles with widespread pain. Early on in childhood, there's an event that puts their brain into a constant state of fight or flight. And usually that's something like growing up with an alcoholic parent, being a victim of abuse. In my case, I was attacked when I was quite young by a young man who later raped and murdered my neighbor. And that put my brain into a constant state of fight or flight for many, many years. But now that my brain is no longer in fight or flight, guess what? Almost all of my pain conditions are gone. So we're going to work on the nervous system in patients with widespread pain. All right, guideline statement number 9. Patients should be educated about normal bladder function, what is known and not known about IC, the benefits versus the risks of treatments, the fact that no single treatment has been found effective for the majority of patients. Why? Hello, because we have phenotypes. And the fact that acceptable symptom control may require trials of multiple treatments. And they encourage patients and doctors to send their patients to both the IC network and the ICA. For more information, to our websites. Guideline statement number 10, self-care practices and behavioral modifications can improve symptoms and should be discussed and implemented as feasible, including making sure you're drinking enough water, making sure that you've changed your diet to remove those foods that we know can irritate the bladder, like, soda or coffee, using some hot and cold therapy to help calm muscles and nerves down, getting good support, maybe even using some over-the-counter supplements. We know that education works because we have research that proves that patients who take the time to learn about the bladder and voiding, and they learn better on how to manage stress and pain, and to avoid those foods, do better significantly in research. And we knew that from back in 2010. Okay, guideline statement number 11. Patients should be encouraged to implement stress management practices to improve coping techniques and manage stress-induced symptoms. How many of you say, hey, my symptoms started when I was under a period of very, very intense stress? Or I flared when I was under massive stress. Why? Because stress can affect the bladder. And stress can intensify pain. It doesn't mean that your quote unquote condition has gotten worse. It means that the stress response has contributed to a flare. So anything that we can do to learn better stress management techniques, it's certainly on point. My life was changed tremendously when I took an anxiety and stress management class. Because it's about skills. Remember, you weren't born with the skills to handle life, much less the life of somebody with chronic pain. If you do struggle with chronic pain or with a new diagnosis, we have to go learn those skills. And we learn those skills in support group meetings like this meeting, but we can also learn those skills from a good therapist who can teach us better on how to handle in periods of very, very intense stress, because it happens. Guideline statement number 12, appropriate manual physical therapy, maneuvers that resolve pain, abdominal or hip muscle trigger points. They can lengthen tight muscles, release painful scars. If appropriately trained clinicians are available, should be offered to patients who have pelvic floor tenderness. Okay, that's absolutely foundational. If you have tight pelvic floor muscles, you should be referred immediately to a pelvic floor physical therapist. Why? Because there's a toll to be taken with tight muscles. When you have tight muscles, you have reduced blood supply. And when you have reduced blood supply to the bladder, and when you have reduced blood supply to the nerves, can they be healthy? And the answer, of course, is no. So we have got to get the blood flowing again correctly and fully. And the way we do that is by releasing these very, very tight muscles. And we have the research to prove it. We have a research study from 2012 that showed that almost 60% of patients who had pelvic floor myofascial physical therapy did better. And there's really no oral medication that's come close to that success rate. Okay, oral medications. Guideline statement number 13. Clinicians can prescribe pain management agents such as a urinary analgesic like pyridium, acetaminophen, NSAIDs, and opioids or non-opioid medications after counseling you about the risks versus the benefits. And remember, this is about shared decision making. It's important that you understand the risks versus the benefits of some of these pain medicines that you can take. Guideline statement number 14, amitriptyline, hydroxyzine, pentosan polysulfate may be administered as oral medication. Amitriptyline, a low-dose antidepressant, has certainly been found to be helpful. When compared to placebo, it acts by calming nerves down. However, adverse events are very common and may compromise your quality of life, including weight gain, loss of libido, sedation, drowsiness, fatigue, nausea, constipation, and hello, dry mouth, dry eyes. So they say to start patients at low doses, and if you can, tolerate to 75 milligrams to 100 milligrams if tolerated. The challenge here is that that's very hard to tolerate high doses. Most patients will stay at a very, very low dose. For example, I was on amitriptyline for 3 months and I experienced one of the cardiac adverse events. It really affected my heart quite badly. And it's been almost 30 years, and I still have some heart issues from that 3 months of amitriptyline. So really important that you discuss the pros versus the cons. It's a rather rough medication to tolerate, especially if you're a little bit more on the sensitive side. Another medication, hi Donna, hi Kayleen, another medication which you don't hear a lot of, but actually has a pretty good grade level is cimetidine. Cimetidine is a histamine blocker. And it has comparatively few side effects when compared to something like amitriptyline. One study showed no adverse event reported at all. It was found to improve frequency, urgency, pain, and nocturia at night. Another oral therapy that can be tried is hydroxyzine, also an antihistamine. Patients with systemic allergies may be more likely to respond to hydroxyzine. The adverse events of side effects were generally not serious, more like short-term sedation and weakness. I know that I took hydroxyzine for a good almost 8 or 9 years. One of the reasons why I liked hydroxyzine is it had a very mild beneficial side effect of being, or not side effect, a beneficial effect of being a bit of an anti-anxiety agent, and I was really struggling with anxiety at the time, so it just kind of kept me a little bit chill. I never noticed sedation with hydroxyzine if I took it at night, but I would never have taken it during the day. I would have been sleepy if I was taking it during the day. Usually when I took hydroxyzine, I took it around dinner time to get enough in my bloodstream to help me sleep through the night. And then by the time it was ready to get up in the morning, it was a tiny bit harder to wake up. But once I was up, I was fine. No sedation during the day. One of the more common side effects of hydroxyzine is nightmares, actually night terrors. It's known for intensifying dreams. And that's why I eventually stopped, is I started having night terrors. And they were really bad, awful, awful dreams. I knew exactly where they came from. And as soon as I stopped the medication, they stopped. Another medication, Angel, we'll get to that. Angel's asking how effective is a pacemaker for the bladder. It's not approved for IC. It's approved for frequency, urgency, and continence. And there's a lot of risks associated with it. But we'll get to that in a moment. Another oral medication that can be prescribed is Elmeron, also known as pentosan polysulfate. Unfortunately, the research is contradictory, with some trials showing no symptom improvement. Others show a slight benefit when compared to placebo. Our big challenge with this medication is it is now associated with really significant retinal disease called pigmentary maculopathy. The symptoms include difficulty reading, slow adjustment to light and or reduced light environments, blurred vision. And it appears that the more a patient takes, the greater the risk of retinal disease. And most importantly, that these visual changes may be irreversible after stopping the medication. So in 2020, the FDA put a new warning label on Elmeron, which states that a detailed ophthalmological history should be obtained in all patients prior to starting the meds. For patients with other eye conditions, they want a baseline retinal examination done before starting it, so you know where you're starting. They want every patient using it to get a retinal exam within 6 months of starting the treatment, and then periodically just to make sure eye changes are not occurring. And if changes in the retina develop, the risks and benefits of continuing treatment should be reevaluated because these can be irreversible. Okay, let's move on to bladder installation. So bladder installations are ideal for patients who appear to respond to like an anesthetic challenge. So these are patients who have pain as the bladder fills with urine, and it gets better once they empty their bladder. But it's a little bit more, it's not quite as easy as I'm making it sound. One of the things that some doctors have done is something called an anesthetic challenge. And that's where you put something like lidocaine in the bladder. And if you put lidocaine in the bladder and all the symptoms resolve for a period of hours, then we know the bladder wall is driving those symptoms. So there are many cocktails that are out there that can be offered to patients. That local anesthetic challenge that I just talked about helps to localize the pain to the bladder, can be done after an office cysto. If that makes the pain go away, that supports a bladder-centric phenotype. But if a patient does respond to that, does not respond to it, that does not exclude IC. Maybe we're going to look for other things. And most of all, these intravesical installations may be very, very helpful during periods of flares. So again, having a rescue installation, if you're stuck in a really intense flare and going through that typical rescue installation protocol of one installation, heparin lidocaine a week for 8 weeks, can really be quite successful in calming those nerves down over time and helping to break you out of that flare, if it is indeed a bladder wall flare. And if, of course, you're not drinking coffee every day. Because if you're pouring acid in your bladder and it's super sensitive, no treatment's going to counteract the damage done by that coffee or that soda. Your job is to create an environment that will support healing of those tissues. All right, procedures. Guideline statement number 18, cystoscopy under anesthesia, done for a short duration, low pressure, may be undertaken as a treatment. In other words, a hydrodistension. The advantage of having a hydrodistension is it will rule out any other funky things going on in your bladder, like a bladder stone. When you do a mild distension, it will generally cause a Hunner's lesion to bleed. Thus, it will help them identify if you have lesions, because if you have lesions, we want to treat those lesions when they find them, etc. If Hunner's lesions are found, in guideline statement number 19, they want them fulgurated with electrocautery or the injection of a steroid. They give some nice pictures of lesions. So if Hunner's lesions are found, fulguration with electrocautery or triamcinolone injection may result in a significant improvement of pain and urinary symptoms for 75 to 90% of patients. Let me say that again. 75 to 90% of patients with Hunner's lesions get better, and their pain gets better when you treat the lesion correctly. That's one of the things that really, really breaks my heart are those patients who have had long-term pain. They were diagnosed with lesions, but the doctor never treated them. Lesions need their own lesion-specific therapy. Guideline statement number 20 is about Botox. It can be administered if other treatments have not provided relief, but patients must be willing to accept the possibility that catheterization may be necessary. Thus, it is not appropriate for patients who cannot tolerate catheterization, and it's relatively contraindicated for patients with evidence of impaired bladder emptying. And in those patients, we want to consider neuromodulation, which just happens to be guideline statement number 21. A trial of neuromodulation may be performed if other treatments have not provided adequate symptom control and quality of life. If a trial of nerve stimulation is successful, then a permanent device may be implanted. And that is, in general, sacral neuromodulation. It's important to know that neuromodulation is not FDA approved as an IC treatment, nor is it for pain. So clinicians and patients are cautioned the procedure is indicated for frequency, urgency, and may be less effective or ineffective for pain. Studies have found that neuromodulation has reduced the need for opioid pain medication. However, IC patients are more likely to request explants, in other words, to have the device removed, and or to report that their symptoms has recurred. Guideline statement 22 is about major surgery, which is only done when all other therapies have failed to provide any symptom control or quality of life. Major surgery should only be reserved for extremely carefully selected patients. Let's see here. The best known predictors of success are an end-stage fibrotic bladder, a small bladder capacity under anesthesia, or the presence of Hunner's lesions that have not responded to treatment. So what are they looking for in a patient where they're considering a major surgery to the bladder? What are they looking for that will show that it probably would not be that effective? Number one, if you have a large bladder capacity. Number two, if you don't have Hunner's lesion. Number three, if you don't have relief from a bladder installation. Number four, if you have tight pelvic floor muscles. Removing your bladder is not going to fix the tight pelvic floor muscles. If urethral pain is a main complaint, removing the bladder isn't going to fix that. If you struggle with neuropathic pain, widespread pain, or if you're a non-compliant patient, in other words, you're failing to respond, failing to follow any of the basic guidelines they're asking you to follow, like hello, not drinking coffee every day. Jennifer says here, I was offered a cystoscope without hydrostension. Is this good enough for a full examination of the bladder? It is if it's the right cystoscope. If that doctor is experienced and they have a flexible cystoscope or narrowband imaging cystoscope, then that should allow them to see Hunner's lesions, and that would potentially keep you out of the operating room. In contrast, if that in-office cystoscope finds what looks to be a Hunner's lesion, then they may want to do a hydrodistension to look more closely at it and treat it, because we want to treat those. Rebecca says, does it help to come off with the contraceptive pill? It certainly can, if that contraceptive pill is restricting your estrogen levels. If your estrogen levels have dropped so significantly that your bladder wall's starting to thin, that mucosal layer is starting to thin, then that makes your bladder more vulnerable. We have a case study that was presented, I think, 2 years ago of an 18-year-old who developed the symptoms of frequency, urgency, pressure, pain. Over a period of a year, she was diagnosed with IC, she was all sorts of UTI, you name it, candida. She was diagnosed with all sorts of crazy things. Eventually, though, somebody asked her, or she figured out, hey, did you happen to start birth control right before this happened? And it turned out she had 2 weeks before she developed these bladder symptoms, she started oral birth control. And when she stopped the birth control, it took about 6 weeks, but all of her symptoms went away. And that's a really good example of how estrogen, or the lack of estrogen, can affect the bladder wall. One of the really, really big things that we're really focusing on now is how to identify widespread pain. And they're actually asking urologists now to use a body map, to actually give you a picture of your body and have you mark X's wherever you feel pain. Do you feel pain in your lower back? Do you feel pain in your head from a migraine? Do you feel pain in your shoulders, et cetera, et cetera? We call this centralized pain. Now, this is something that we all pointed out years ago, especially those of us in the IC patient population. One of the reasons why almost every major IC research study failed of trying new treatments is because you can't put apples, oranges, and bananas in the same study and expect success. It just doesn't work that way. And our challenge here is that companies have invested millions trying to bring new drugs onto the market, only to have their study fail. Why? Because you're combining a Hunner's lesion patient with a pelvic floor patient, with a widespread pain patient, with a just estrogen atrophy patient. And now our National Institutes of Health and the AUA clearly recognize that you cannot expect what we call a heterogeneous patient population to respond equally to the same treatment. And the secret for the future is to look at the distinct patient groups. So what you're going to see now are studies designed for Hunner's lesions. What we're going to see now are studies designed for the bladder wall, or studies designed to calm the central nervous system down for those of us who have widespread pain. So what I really love about this is they're pounding away at doctors to understand that we are a heterogeneous population and that we must phenotype these patients to find the best treatments. And we must phenotype patients in research studies if we're really going to give that new treatment a chance to succeed. Another point that they made, and this is a research study that I had never seen before, is that they have now been able to prove from a 2023 study that patients with widespread pain will affect the results of IC clinical trials in a negative way. And that makes sense. So here you've got frequency, urgency, pressure, pain, but you got IBS, vulvodynia, et cetera, et cetera. Now you're thinking you have a bladder disease. They all thought you had a bladder disease, but now we know that that's a central nervous system problem. And it's the patients with a widespread pain that are often the most challenging, myself including. So what this study found is that patients who had low widespread pain responded better to local treatments like Elmeron in the bladder, hydroxyzine, et cetera, et cetera. Patients with high widespread pain did much better with systemic treatments like amitriptyline. So this is very meaningful. So their take-home slide, treatment should be based on the patient phenotype. All right, so hold on a second. So nothing really super surprising there. I mean, because we went through this last year, I just really like some of that new research. Now I have not had a chance to listen to this part of it. I'm just going through slides right now because they don't have the recording up yet because it happened this morning. Dr. Ann Ackerman is our biome specialist, because here's a challenge. IC feels like a UTI. It feels like a UTI. Everybody who gets IC assumes at first that they've got an infection. Everybody. And the odds are you had many, many urine tests over the years. And every time you flare, you call the doctor, hey, I think I have an infection. Only the culture results come back negative. So now that we have next generation DNA urine testing, they are doing a much better job of trying to understand what lives in urine. Urine is not sterile. That microbes live in the urinary tract. And that these are symbiotic polymicrobial communities. That there are at least as many bacteria as there are cells in our body. They are highly diverse. They are highly specific. Thus, the biome in your nose is going to be very different than the biome in your stomach, which is going to be very different than the biome in your mouth versus the biome in the vagina versus the biome in your bladder. Even the biome in your urethra or your biome by your kidney, they're all going to be subtly different. So what do these bacteria do? What do these good bacteria do? Well, in the gut, this is what we know they do. They produce neurotransmitters that interact with your nervous system. They compete with pathogens for resources. In other words, they eat all the food so that the pathogens don't have enough food to grow. They help to regulate the tight junctions in your bladder and in your bowel to keep them strong and healthy so stuff can't get through your bladder wall into the rest of your body. They produce their own like antibiotics. They're natural antibiotics that we call antimicrobial compounds. They prime the defenses, the immune defenses and the skin defenses. They help to degrade harmful compounds, and they help to create and maintain the urothelium. When that biome is damaged, bad things happen. So what can happen is the bladder wall can break down, the urothelium can break down, urine can now get deeper into the tissue. This causes inflammation. This then causes nerves to become very sensitive, mast cells to release histamine, et cetera, et cetera. So the secret to a healthy bladder wall, in part, is based upon a really good, healthy biome. So we have a couple of different ways to test for what's living in the bladder. They can do a urine culture or they can do a next generation DNA urine test. The advantage of a next generation DNA urine test is that it's more sensitive. It can detect difficult to grow organisms. It can detect minor species, whereas a urine culture will only identify 1% of organisms that are thought to be cultivable, and it underestimates the diversity. So a urine culture is cheap, it's fast, but it is not necessarily going to show everything in there, and it's going to miss a lot. A next generation DNA urine test is really sensitive. It can find difficult to grow species, but it can overestimate diversity, and it can be very costly and time consuming. Let me go through this a little bit. So in the IC patient community, there's been research community for the last 10 years, there has been a lot of research trying to understand if the urinary biome is different in the IC patient when compared to people who don't have bladder symptoms. And multiple studies have been done over the years, and they all came to the same conclusion. They found that IC patients had a normal biome, but that it was less diverse. There were not as many of the other bacteria, and that there was more lactobacillus. So there was, they were looking for that superbug. They were looking for that Helicobacter pylori, which was found to be the cause of stomach ulcers. They were hoping that that's what they would find in the bladder and IC patients, was this elusive bacteria. They never found it. Instead, what they found was less diversity, but more lactobacillus than normal. Lactobacillus, good bacteria, right? They found more lactobacillus in younger patients and less lactobacillus in older patients. They found that in younger patients, their biome was really dominated by lactobacillus, and that's a good thing. But in the patients over the age of 60, that lactobacillus comes way down, and lots of other bacteria step in and start to play a role in the biome of somebody who is older. Let's see here. I wish I could show you these slides. I cannot do that. So here's the slide. So again, under the age of 45, dominant in lactobacillus. Over the age of 60, we've got a lot of E. coli. We've got much smaller amount of lactobacillus. We've got Gardnerella. We've got Corynebacterium. There's a lot more bacteria in that patient who's older. And interestingly, for the patients who had bladder pain, there were very, very specific bacteria that were found in these pain patients. So what they found was dominantly something called Lactobacillus iners. Now, Lactobacillus iners is a new lactobacillus that they didn't really know of 10 years ago. That it was a DNA urine testing that really helped them see, hey, there's a species of lactobacillus that we really haven't seen before called Lactobacillus iners. Iners is associated with more pain. Einers is associated with more bacterial vaginosis, recurring chronic bacterial vaginosis. So patients who had more pain had more lactobacillus Einers. Patients who didn't have the pain did not have the lactobacillus Einers. So it correlates with pain. So Dr. Ackerman, who again is this really one of the best biome specialists in the world, and we talked about this last year, she decided to reproduce this data to see if she reproduced the studies in her lab at UCLA to see if she could find anything funky. And she, again, like all the other researchers, initially found a normal biome, less diverse, more lactobacillus. But then she applied phenotyping to it. She said, okay, that's interesting. Now let's see how it changes based upon a patient's phenotype. And what she found is that patients who were pelvic floor driven, normal biome, no problems with the biome. Patients who were bladder specific had lactobacillus Einers. Patients who had pain beyond the bladder, but not in their bladder, were more dominant in E. coli. So that's really fascinating. So here's the problem with lactobacillus Einers. It does not behave like a normal lactobacillus. It does not inhibit fungus. It does not produce some of the normal chemicals that good bacteria produce, like lactic acid and hydrogen peroxide, which will kill bad things. And it produces a toxin which can actually break down skin. So lactobacillus Einers is actually a pathogenic lactobacillus. This was published in 2020. This was our first research study with that just a couple years ago. So they are in the process now of trying to study a little bit more about lactobacillus Einers. Now, I dove into the research when this came out last year, and as I was reading it, what lactobacillus Einers appears to be a really opportunistic lactobacillus, and it's very, very quick to grow. And so for patients who have been on antibiotics, long-term antibiotics, one of the first bacteria that appear to grow back and repopulate the biome is in fact lactobacillus Einers. And we just don't have a lot, we don't have a lot of information on that yet. But I'm hoping that I'm going to be able to get more information for you as these recordings are released. Now, another thing that Dr. Ackerman pointed out is when you think about a UTI, it's not just bacteria. We got to look at fungus. And here's the deal. They have now found increased levels of fungus, candida, in the urine of patients with bladder pain in IC studies. So, for example, in control patients, they found, let's see, I can't even give you the numbers. You're not going to understand these numbers here. All I'm going to tell you is they found double or triple the amount of candida in some IC patients as compared to normals. And in overactive bladder patients, they really didn't find any. So in patients who are flaring, this is very, very interesting. So patients who are flaring have less bifidobacterium, which is a good bacteria. It has less lactobacillus substantially. It has less of certain other ones, but it has significantly more candida or fungus in their bladder. That research came out in 2015, and that was a National Institutes of Health funded research study. So one of the things that I constantly say to patients, hey, when you think about bladder infection, don't just think about bacteria. You need to think about fungus and virus. Because those happen. We know COVID can infect the bladder. We call that COVID cystitis. But we have very validated research that has found candida in patients who are flaring. So if you flare when you eat sugar, That's something to note. If you flare when you eat carbs, those sugar and carbs feed candida. That's significant. And if there's ever a group of patients who are completely overexposed to antibiotics, it's us, because we were all put on antibiotics. And a lot of us were put on long-term antibiotics. Think about what that did to our biome. Killed all the good stuff. Then the lactobacillus iners grew. Lactobacillus iners doesn't control fungus. Now we've got an overabundance of fungus too in some of us. Now, what's interesting is I ate something 2 days ago, which kind of gave me food poisoning. Like I was in the bathroom with the runs almost all day yesterday. And then I had terrible gas. And I was trying to figure out, okay, what did I eat? And I had eaten some almond crackers, and I know nuts often don't do well for me. But I had also eaten some fruit, a lot of fruit. And I've been going for a few more carbs than normal. And I really have to wonder, I mean, I'm much better today than I was yesterday. I was pretty miserable yesterday. But when you give fungus sugar and carbs, what does it do? It grows and it starts to produce gas. And I had a lot of gas yesterday. It's fascinating. I will also say too that we have a local popcorn company that makes a lot of different flavors of popcorn. And one of the ones that I used to like, it's called Hippie Dust. And it has nutritional yeast in it. And the last time I ate it, holy moly, did I have gas for 24 hours afterwards. And I think that repopulated my biome, maybe with some yeast that could have messed things up a little bit. So anyway, Candida is associated with IC. Candida abundance increases with as Candida abundance increases, increasing bladder pain occurs. She says, fungi are part of the urinary microbiota, even in healthy subjects, and fungal patterns are associated with bladder pain, but there is no H. pylori for IC. It's just much more complex microbial communities that appear to be playing a significant role in some of our symptoms. So I guess the take-home point here from this, this is the best class of the year for doctors, is that this is a very, very diverse community. Our goal now is to phenotype patients to try to identify which group you fit in. And then based upon which group you fit in, we want to focus on the treatments for that unique group. And that absolutely makes sense. And now that we've got this new biome research, this is opening up a whole new line of study in the IC patient population. Because again, if you're pelvic floor, it's muscle. If you're widespread pain, it's the central nervous system. But if we're dealing with bladder-centric symptoms, could there be an issue with your biome? Or as some people say, very difficult to culture UTI? Is this like a good side and a bad side to it? Yes, number one, we're learning more about the biome. And yes, there could be an imbalance in the biome, but it's not bacteria. It's not pathogenic bacteria that you would take long-term antibiotics for. It actually appears to be this unusual lactobacillus iners, which is probably the result of taking too many antibiotics. But there's just a lot more research that they have to do on that to make any really good, credible claims for that. So that is, Michelle says, I'm new to this disease and I'm pretty devastated. Michelle, number one, it's not a disease. And the great majority of us, it's a neuromuscular issue as compared to a bladder disease process. You have to understand that the symptoms of frequency, urgency, pressure, pain, even though it feels like a UTI and it feels like it's coming from your bladder, it might not be coming from your bladder. In fact, for most of us, it's not. It can come from very, very tight pelvic floor muscles. It can come from other conditions in your pelvis, like endometriosis, fibroid tumors, things like that. And so we don't call IC an incurable bladder disease anymore. It is a neuromuscular disorder for the great majority of us. But we have phenotypes now. And so now your job is to try to figure out where you fit. So, and that's the doctor's job, is to work with you to try to figure out what group you're in. So if you, for example, have very severe frequency urgency pressure pain and or you have blood in your urine, like visible blood in your urine, we're going to really suspect Hunner's lesions. That's 5 to 8% of the IC patient population. This is a very distinct group of patients, and they have their own specific treatments, and the treatments work. The second thing we're going to look for is bladder wall-driven symptoms. Pain is your bladder fills with urine that is relieved by urination. And in this group, we're going to look for 3 distinct things. The first thing we're going to look for is a chemical injury to the bladder. So if you've gone through chemotherapy and the chemo would have damaged your bladder wall and caused these symptoms. Or if you drink a lot of diet soda or you drink a lot of coffee or energy drink, that can injure the bladder directly. The bladder can be hurt like any other part of the body. The second thing we're going to look for is your age and your estrogen levels. Because it turns out that your bladder wall needs estrogen to produce that nice thick coating of mucus that normally protects it. So if your estrogen levels have dropped because you're on birth control or you're on Lupron or you're just getting older, then your bladder is not going to be able to defend itself as well. The bladder lining is getting thinner and more vulnerable. That is not a disease. That's just estrogen atrophy, and we're going to treat that with topical estrogen to give that skin what it needs to produce mucus again, and maybe do a few things that can help to coat the bladder, like some of the supplements like Bladder Builder and Bladder Rest might be helpful there. The third thing we're going to look for in this patient group is chronic UTI. And that's where the doctor needs to do their due diligence, do a good amount of urine culturing. Let's see what they find. Maybe do some next generation DNA urine testing just to see if there's anything funky going on with your biome. But that's still a very small group of patients. Our biggest group of patients by far are the patients who have very tight pelvic floor muscles. These are the patients whose symptoms began after having a baby or falling on their tailbone, breaking their tailbone. If they were an athlete, if they were a cheerleader, a gymnast, a football player, a bike rider, horseback rider, that when the pelvic floor muscles are injured, they get tight. And as they get tight, they start to squeeze the blood vessels that support the bladder wall and support other tissue and the nerves. And that causes ischemia. The bladder is not going to be healthy if it's only getting half the blood supply it needs. So if you have pain with intimacy, if you can't start your urine stream right away, if you're hesitating 5, 10, 15, 20 seconds before you can relax enough to release urine, that tells us that your muscles are tight. If sex is painful, if you have vaginismus, that tells us that your muscles are tight. If you have sciatica, pain that shoots down your leg, that tells us that your muscles are tight. And your treatment for that is going to be pelvic floor physical therapy, and it's stunningly successful. And that is why one of the reasons why I'm symptom-free now. Bladder treatments did nothing for me because I have a healthy bladder. My problem really dominantly was my pelvic floor and my nerves. The fourth phenotype that we use is pudendal neuralgia. These are patients who have positional symptoms. They're fine when they stand, but when they sit down, it hurts, or when they bend over, it hurts, or they feel pins and needles. They feel areas of numbness. They might feel a vibration, which I feel right now on my left butt cheek from sitting here. That is my pudendal neuralgia. It doesn't hurt, it just flutters. If you have PGAD, where you feel a sensation of arousal, even though you're not aroused right now, and it hurts and it's uncomfortable and it's disgusting and you don't want to tell anybody about it because it's super embarrassing, that's a sign that muscles are squeezing the pudendal nerve. So anytime your symptoms are positional in nature or pins and needles, things like that, we're always going to be looking at muscle squeezing nerves. So again, we're going to go back to that pelvic floor physical therapy, but we're also probably going to do some things that will help calm some of those nerves down. And then last but not least, we have to look at that widespread pain patient. Do you have multiple pain conditions? You have bladder pain, Do you have vulvar pain? Do you have bowel pain? Do you have fibro? Do you have migraines? Do you have TMJ? Do you have super, super sensitive skin? Do you have a wicked sense of smell? And do you struggle with anxiety? Now we know what that is. This is also my subtype, and that's 30 to 40% of IC patients out there have widespread pain. That's central nervous system. And for patients with widespread pain, what we're going to be doing is doing things that will calm that central nervous system down. When we calm the nerves down, the level of the pain goes down, the sensitivity goes down. Now, interestingly, one of the big questions for those of us who have widespread pain, and for me, it happened in my 20s when I got virtually all of them. And so while my friends were out getting married and having babies, I was laying in my damn bathroom every morning in the fetal position having bowel spasms. It was awful. Why me, God? Why me? Why did I have all these crazy pain conditions? Obviously, I was extremely depressed. Who wouldn't be? Because I was stuck at home. I wanted to live. I wasn't living. Well, now we know why. What the research shows is that for 80% of the children who develop widespread pain as an adult, there's a physical trauma in childhood. So I broke my tailbone in 7th grade badly. And that was the year my frequency urgency first started. So tailbone injuries are common. And one of the challenges of being a child is that parents don't listen to you when you're in pain. We now know that 14 days of pain will put the brain into a constant state of fight or flight. And that's what we find in widespread pain patients. At 24 hours a day, 7 days a week, your brain thinks your life is at stake. That tells us the central nervous system is driving a lot of these symptoms. So for 80% of the children, it's a major physical injury. So I've worked with patients who have been, I still remember a gentleman that I was working with who was hit by a car badly and had a crushed pelvis when he was a kid. And by the time he was in 50s, he had all the pain conditions, all from that original trauma. Now, for the other 20%, it's a history of bullying or abuse. And the best example that I can give you is growing up with an alcoholic parent, just working with another patient this week. That exact scenario. And if you grew up with violence in your home, your safe place was at school. So you wanted to go to school. And you knew when school was out, bad things could happen. And so fight or flight turned on as you were walking home from school. And the closer you got home from school, the more hypervigilant you became. And when you got home, you started looking to see if that parent was home or if it was somebody coming back from work. You dreaded them coming back from work because that's when you knew they were going to start drinking. The more they drank, the scarier you got. I was working with one patient who would literally lock herself and her siblings in the bathroom when dad was drinking. And every night, dad would break the door to get to them and beat them because he was drunk. Think about what that did to that child's brain. Of course, that brain was habituated into fight or flight. Imagine living with that for 10 years. Your brain began to believe that that isn't even right. Your life was at stake. You were being abused. Of course your life was at stake. Fight or flight, it's the way your body responds when your life is at stake. And what happens over time is your brain gets habituated into that. 21 days of abuse and bullying will put that brain into a constant state of fight or flight. The ramifications of that over the lifetime can be challenging if we don't get that brain out of fight or flight. So the blessing now is that, number one, I know that this was not my fault. I know that I did nothing wrong. I was a victim of a childhood trauma, 2 childhood traumas. I was attacked violently and I had a major physical injury. That's why I ended up with all these painful conditions. It was never my fault, and it's not your fault. And now we know how to calm it down. We have to get that brain out of fight or flight because you're an adult now and it's safe and it's over. So I am always happy to work with anybody on the phone who's been a victim of a childhood adverse event to try to help you understand some of the techniques that you can use to retrain your brain back down. I hope that makes sense. So, Michelle, I hope that makes sense here. We have distinct patient groups. If you come on over to the IC Network website, we have a whole section on phenotyping. You can read about those phenotypes and try to figure out where you think you belong. And if you'd like to call and chat, you're always welcome to give us a phone call. We have our 800 number back there. It's on our website. Always happy to help. Just remember that we're not doctors. We can't diagnose you. What we do is try to educate you and send you back to your doctor with a new set of questions to try to confirm that. Michelle says, I had a horrible flare-up on Friday night, stuck in a public bathroom for 20 minutes until I could let the azo set in enough to get up and walk to my car. Oh, Michelle, honey, I'm so sorry. What do you think triggered your flare? Do you think it was something you ate or drank? I remember one of my worst flares happened in a movie theater after I drank 7-Up. Besna said, does anyone have experience with Cysto Protect? Cysto Protect was literally the first chondroitin supplement invented. We actually did the product launch for Cysto Protect over 20 years ago. Dr. Theoharides invented it. He was an IC researcher at Tufts University. He did a pretty sizable study, I think, of 257 patients who took it, I think, 6 months. And there was good success with that. I think 57% somewhere. I mean, it's been a while, but it showed success for some, but not all patients. And so Cysto Protect really revolutionized supplements because up to that point, really all we had was aloe or quercetin. And Cysto Protect actually makes a lot more sense. A chondroitin-based supplement makes a lot more sense, especially for that patient with estrogen atrophy when we're going to try to coat and protect the bladder a little bit more. Since Cysto Protect is invented, we have some other supplements which are actually newer and more advanced and more innovative. The first one was Cysto Renew. Dr. Gio Espinosa invented that. Unfortunately, we cannot get that anymore. That company may have permanently discontinued it. We're told that it's indefinite hold. The next supplement that was invented after that was Bladder Builder. I continue to believe that Bladder Builder is the best supplement we have now because it has more ways of helping. It's got some of the same ingredients as Cysto Protect, but it's added a few more ingredients. It's got some beneficial probiotics for the gut combined with PEA, palmitoyl ethanolamide, to calm nerves down. It is a robust formula. If you flare when you take a probiotic, we would say don't try it because it has probiotics in it. So the next supplement would be Bladder Rest for a good night's rest, which is a very simple formula without all the extra ingredients in it. And that's where we suggest patients who are more sensitive start. Any of the supplements can cause a little bit of a stomach upset, and which is why we always say go slow. Start with 1 capsule, see how you feel. You do that for a couple of days, see how you feel. You can go up to 2, then you can go up to 3 or whatever the manufacturer's recommended dose is. I will tell you, when I took Cysto Protect, it gave me a loose bowel. And so I felt it. It felt good in my bladder. It felt like warm cotton candy in my bladder, but I couldn't deal with the bowel issues. So that was not one that I could take, but you and I are different. It might be reasonable for you. All the supplements are available over on the IC Network website. You can learn about those there. Anne says, with IC, do you usually get negative UTIs? Yeah. Yeah, our urine cultures are usually negative. And that's not surprising with all the urinary biome research that shows that we have a normal biome. And it's only this new research from Dr. Ann Ackerman where we are finding maybe a pathogenic lactobacillus, but that's very, very new. And so we have to have a lot more research before we can say conclusively that that is a cause of bladder wall-driven symptom. But remember that the great majority of IC patients, it's not their bladder anyway, it's nerves and muscles, and they are going to find no unusual bacteria in their bladder. And that's what Dr. Ann Ackerman's research found, is that patients who were pelvic floor centric had a normal biome. So absolutely fascinating here. And Jennifer said she takes Cysto Protect, and it's an older supplement, but a good one. Excellent. Yeah, we just reordered Cystoprotect. We have it in our store, but we're getting down there. We also had a lot of new research that was presented at AUA this year. I have not had a chance to listen to the the podium sessions. That's where they discuss them. And so I will have more on that near the end of the month. I'm probably not going to stream next Sunday because that's the anniversary of my dad's death. It's also Mother's Day. And I will probably be crying all day. And I will probably be going to the cemetery and putting flowers on their graves. So, but hopefully I will be back in 2 weeks. Knock on wood. Jennifer says, with a cystoscope, can a smaller injuries in the gag layer be identified? It depends upon the type of cystoscope they have. There are different types of cystoscopes. Older cystoscopes are not as they're not as capable of distinguishing smaller changes, whereas some of the new cystoscopes are. So old technology, not so much. New technology, probably. Also, something like a bladder stone, it's really easy to see. Really, really easy to see. I mean, because it sticks up. If you have cancer, it's usually really, really easy to see because there's a bunch of fluid, there's a bunch of tissue in there. Lori says, so grateful for your knowledge and what you offer us, even to those way down here in New Zealand. Hello, New Zealand. Hi, Lori. I'm doing a lot of coaching with patients in New Zealand these days. Finding the right times are always challenging. I do coaching for patients all over the world. Always happy to do it. And our challenge here is that resources in other countries are usually very, very, very limited. New Zealand does have an IC support group. It's run by a lady named Dot Milne. Dot Milne. Yeah. You're being diligent with your diet. You have your first physio appointment next week. Yay! Excellent. Excellent. Let's see what that physical therapist finds when they actually study your pelvis. That's probably the single most important visit for every one of us, is to really get a neutral set of eyes and fingers studying that pelvis, touching those pelvic floor muscles to see if we can find any abnormalities there. Zavra says, hey, Jill, do you know if you have to take biofilm disruptors before you do a next-gen test? No, absolutely not. And biofilm disruptors, listen, there's a lot of people out there making a lot of money selling all sorts of stuff about biofilms. And you're really treading in dangerous territory, in my opinion, because there are biofilms, remember, like I was saying from this presentation from the AUA, there are as many bacteria in your body as there are cells. Bacteria play very, very, very important roles in our health. Some bacteria, for example, produce the food that the cells lining our bowel eat. The human body does not make this food. Good bacteria makes the food. So when you kill that bacteria, you kill the food source, which then kills part of the cells in the bowel. If I remember correctly, and because I've gone to a lot of meetings over the years, biofilms are found throughout the body. And are they all bad? No, probably not. So again, this is, God, if I could go back to grad school and go into microbiology, I would love to get a PhD in antibiotic resistant infections and biofilms. I mean, this is it. This is where we are. The concern is if you take something which breaks open all the biofilms in your body, what's going to happen? We don't know. We don't know. So this is a really new area of research. And I was reading something about the brain, biofilms in the brain, and they have actually been able to track uh, bad bacteria in your mouth to biofilms in the brain and biofilms in different parts of the body. And so if the biofilm is containing the bacteria so that it's not infecting cells, isn't that maybe a good thing? So I don't think we have enough research right now that really understands the pros and cons, risk versus the benefits of breaking up those biofilms. And during COVID, a lot of meetings started. A lot of meetings stopped, but there is this great UTI group, a working group. I just attended a 1-hour seminar with them. That was fascinating. I was just wondering if we have any new biofilm nanoparticles for oral biofilm treatments. Clinical Microbial Infectious Diseases 2015 has a guideline for the diagnosis and treatment of biofilm infection. I just don't. Here, hold on. Let's see if there's anything new. What is this? How xylitol, gluten, and lactose change the human gut microbiota, E. coli, and lactobacillus biofilms. The human gut microbiota is composed of many viruses, bacteria, and fungi. E. coli representatives play a crucial role in the metabolism of lactose, vitamin synthesis, immune system modulation. E. coli forms a biofilm on the epithelial cell surface of the intestine that can be modified by diet compounds. In the present study, we impact the probiotic-derived Lactobacillus rhamnosus strain on non-pathogenic E. coli biofilms. The biofilms were also treated with gluten, xylitol, and lactose. It was found that Lactobacillus rhamnosus is strongly inhibited by gluten and the monospecies biofilm of E. coli by xylitol. They conclude probiotics might be helpful in rebuilding the gut microbiota after broad-spectrum antibiotic therapy, but only if gluten and lactose are excluded from the diet. That's in April 2024 Nutrition. And man, I suck on xylitol all the time. Gee willikers. Hi, Gay. Hi, Robin. Zara says, physio checked me and the pain went upwards towards my stomach. And she said, this is because I've had infection and inflammation. She will be working on myofascial massage with a wand. Excellent. Love it. Love it, love it, love it. Now, just so you know, we're not filming on Facebook. The Facebook controls changed. So we're only filming on YouTube today. I do not know what the heck is going on with Facebook. I have no freaking idea. They do this a couple of times a year. So I'm sorry, I'm looking over to the side. Normally I'm looking at Facebook when I'm looking straight, and I'm looking at YouTube here. So YouTube is set up over on this other computer, even though, you know what? I can just move this. You can see my messy office. All right, any other questions? So we've been going for an hour and a half, about an hour and a half. I'm not 100% today. I'm a little scattered. The other thing I could do, Robin says, my pelvic floor therapist says I'm not tight at all, just a small spot on the left, yet I'm burning like crazy and uncomfortable. So if you're burning like crazy, the question number one is where? Where are you burning? Is it on the outside or is it on the inside? If it's on the outside, on your skin on the outside, or if it's in your vagina, then we're going to be really looking at estrogen atrophy. That burning is usually going to come from two sources. I mean, it's most dominantly going to come from two sources. Either the quality and health of your skin, so estrogen atrophy can cause burning on your vulva, in your urethra, in your vagina, in your bladder. But the other thing is going to be very, very tight pelvic floor muscles. If you've got tight pelvic floor muscles, that also can account for that. Jennifer says, I see ads for pelvic wands, but what instruction do you need for them? I would hate to worsen my pelvic floor. Normally, it's your physical therapist who teaches you how to use them. I am bringing on a new line of wands. We just did our order last week, and so I'm bringing in the curved ones, but I'm also bringing in the vibrating curved ones, which get rave, rave, rave reviews. I'm also bringing on a new lubricant to use with the wands. I'm bringing in a new balm for estrogen atrophy and even some boric acid suppositories for patients who are struggling with candida infections. So we're going to definitely have quite a few new products in the IC Network shop. Ultimately, where's let me see if I can, let me get this. Okay. So this is the wand that we sold for many, many years. It's called IC Relief or Easy Magic. And the company sold, so you can now go to desertharvest.com if you want to buy this wand. One of the reasons why I like this wand is that it's Pyrex glass. Super, super easy to clean. And the shape of it, in my opinion, is pretty perfect. But we've got other ones coming in too, because designs change and it's all about what works for you. What works for me might not work for you and vice versa. So here is your pelvis, right? There's your pelvic cavity. And oops, my vulva fell off. Okay. So here's your front of your pelvis. Here's your pubic bone. And I want you to notice here that the muscles are on the inside of the bones. Do you see that? Okay. Here's the back of your pelvis. So we've got your vertebrae. We've got your sacrum. And where you see these 8 holes, that's where nerves come out and go into your pelvis. And of course, we've got your tailbone. Tailbone down here. I really want you to look at everything that attaches to the tailbone. The tailbone does not just hang there. The tailbone is the true center of your pelvis. You have muscles that go to the left and you got muscles that go to the right. So how did they reach these? Hello, finger. This is what a physical therapist is going to do, is they're, especially at that first examination, is they're just going to touch muscle groups. They're looking for tension patterns. A healthy muscle feels like a raw chicken breast. It's soft and pliable, but it has substance. A tight muscle feels like painful beef jerky. So when you have that pelvic floor assessment, they're just going to touch muscle groups. They're just looking for funkiness on the left or right side. And it's quite often the patients will only be tight on one side. I'm tight on my left side. I'm fine on my right side. I'm tight on my left side. Why? Because I have a problem with my joint, my SI joint, let's see. So your SI joint is where your sacrum connects to your hip bone. There is a long joint right there called your SI joint. And this joint is normally very stiff. It's not supposed to move. But if, for example, you were a tennis player, a racket sports player, if you suffered any injury, that joint can start to move. And believe me, it hurts when it moves. And sometimes it even dislocates, and that sucks. I will tell you from personal experience that really, really hurts. So if you have a bony structure abnormality on one side, basically what happens is the muscles lock down tight to hold that bone in place. All right. So anyway, the physical therapist is going to be using a gloved finger on these muscles. But what do you do when you get home? Because you can't reach that. You might be able to get an inch in. You're not going to be able to get far in. That's where a wand comes into place. Because you can put a wand in there and massage those muscles too. See that? It's actually really easy to do. And sometimes you strum. Sometimes you can strum across. It's so hard for me to hold this. Sometimes you go the length of the muscle like this. And sometimes you strum across the muscle like this. It's always hard for me to demonstrate that because it's mirrored on the other end. So anyway, it's hard to demonstrate. Now I will be very honest in telling you that there's a big learning curve with a wand. I mean, when they gave me my wand, she like told me what to do. She kept saying it's an S shape, and I'm like, it's a J shape. It's a capital J shape, and I go home and drop trout, lay on my bed, put my feet up on the wall, stick it in there, going, I have no freaking idea what to do here. None. And it's true. I really didn't know how to do it. And I tried, and I was just touching things with the wand, and it made absolutely no sense to me. And I called her or sent her email and said, I don't get it. What do I do? She goes, it's a J shape, like a capital J, right? Like a capital J. So she goes, move it in a J shape. So I go back, drop trout, put my feet up on the wall. I'm sorry, the J shape made no sense to me at all either. And it wasn't until I read this book, Breaking Through Chronic Pelvic Pain, that I finally understood the J shape. And I will show you the J shape because it goes right back to your tailbone. So again, think about a capital J. Whoops. Oh, I hate looking at it reverse. It's so awkward for me. So imagine two capital J's touching in the middle. You've got a J that goes up in this side, and you've got a J that goes up that side. That's the J shape. And so it's really just gently moving the wand along the length of the muscles, and eventually you're gonna figure out what a healthy muscle feels like and what a tight muscle feels like. If it's tender to touch, it's probably tight. That's where I tend to focus my work. So if I'm starting to have rectal pain, if I'm starting to feel a little bit more, I can always tell how my muscles are based upon how I pee. If I can't urinate on command, if I'm stopping and starting, I always know my muscles are getting tight. And so that's when I'm going to get my wand out, and I'm going to start working with those muscles. And it only takes about 5 minutes to massage the muscles and get them feeling better. So Robin got the Intimate Rose wand, and that's what we're bringing on. We're bringing on all the Intimate Rose wands in the IC Network shop. Robin says, can it be a pudendal nerve issue? I fell 3 years ago hard on my tailbone and was recently carrying a box of wood flooring, and it felt like I had a stick in my ass. So one of the you're not alone. One of the symptoms of having very, very tight muscles is it can feel like there's a foreign object up there in your vagina, in your rectum, in your urethra. Feels like something's stuck up there. For me, it felt like somebody was putting a a really tight, pushing a really tight funnel up my urethra or up my vagina. There was a pulling, pushing sensation. And the bladder does not cause a pulling, pushing sensation. The muscles cause a pulling, pushing sensation. Now, the pudendal nerve issue, remember, nerve pain is very sharp and shrill. It's very electrical, pins and needles, stuff like that. Areas of numbness, or just, only a couple of times. I mean, the cool thing about doing your own pelvic floor work is that you actually see it's very easy to do, and it usually doesn't hurt because there's really not a lot of pain receptors down there. And I was always surprised when my physical therapist, she was basically rubbing right here, right alongside the bone, and it never hurt. And she said, that's because there's no nerves there. There's no nerves where I'm touching, so it's really not going to hurt there. And only once or twice have I maybe pushed too hard and felt like I was starting to push on a nerve, and I immediately backed off. Nerve pain really gets your attention, and you stop immediately. Really, internal pelvic floor work really doesn't hurt. I never really found hands-on physical therapy to be painful. I'm one of those people where I laugh, I giggle when people are doing weird things like that. And so the physical therapist is usually watching your face to see if you're grimacing. I really never found hands-on physical therapy incredibly uncomfortable. But I will say I didn't feel it until I started walking out to my car. That's when I went, oh, wow, we have worked on these muscles here. And when I actually sat in my car, that's when I really could tell that those muscles were a little bit on the tender side. But no regrets, because now I know that almost all of my symptoms, from my rectum to my vulvodynia to my bladder issues, are all being driven by very, very tight muscles. Even pins and needles in your pubic hair can be caused by muscle squeezing nerves. It's crazy, but it's great because now we can fix it. We're not going to waste decades doing bladder treatments when you have a healthy bladder. I mean, listen, if you have a healthy bladder, they do a cystoscope and there's nothing in your bladder. Celebrate that for what it means. It doesn't mean they doubt your symptoms. What it means is that maybe it's not your bladder that's a problem. Maybe it's something outside of your bladder that's a problem. So I don't know if Kayleen is still in her or not, but her story is very, very interesting, and she has shared this in our last meeting. What makes Kayleen very, very interesting to me is that she'd been diagnosed with IC for a couple of years, real genuine symptoms, really struggling. But she said something she never said before. That is, when she pushed on her belly button, she immediately got bladder pain. Immediately got bladder pain and beyond. It's like, huh? How can pushing on your belly button trigger sharp bladder pain? What's the connection between the belly button and the bladder? Well, there really is a connection. It's actually called a urachus. And it turns out that in a fetus, I mean, what happens to urine in a fetus? How does the body handle that when that baby can't pee it out? Well, what happens is that there's a little tube that connects the top of the bladder with the belly button, which goes to the mom's placenta. And that's how a fetus drains urine. It's called the urachus. And normally when that baby is born, the urachus shrivels up. But in 2% of adults, it never shrivels up. And that they really do have a tube connecting the top of their bladder to the belly button. So how do we know that? Well, because they have a wet belly button. That belly button is periodically wet, or that might have a dried crust on it. And so one of our members shared when we first talked about this a month ago that he'd had a wet belly button for 50 years. And that was urine leaking up out of his bladder through his belly button. Sometimes what happens is part of it shrivels up and part of it doesn't. And then what happens is you end up basically with a cyst. You got urine that collects in this area. It cannot drain. It becomes very, very infected. And sometimes patients even get septic from it. And it can even cause cancer. And so I just put on the IC Network website a case study of Kayleen's story with a lot of supporting blogs, as well as 3 additional case studies of well, one was a child, an 11-year-old, who had a giant urachal cyst. And his symptom was frequency urgency, and he felt like he wasn't emptying his bladder. They take him to the doctor. The doctor does a sonogram. The doctor goes, well, yeah, there's a lot of fluid in your bladder. You're obviously not emptying your bladder. So they put him into bladder training, but it didn't work. And the young boy kept saying, I'm not emptying. I can't pee. I don't feel like I peed. And when they went back and they did better testing, what they found was this giant cyst on top of his bladder filled with fluid. And it was big. It was like 8 centimeters by 6 centimeters. I mean, it was, maybe like this big. And it was a urachus that had not completely shriveled up and gone away. And when they surgically removed it, it went away. And that's a good thing, is any of these urachal abnormalities are usually completely curable just by removing it. And then there was a 23-year-old who had one. And then the last one was an interesting story of a 25-year-old who was pregnant, and she was having urinary symptoms, and like they thought it was infection. They gave her antibiotics. Then she had her baby. And the symptoms really, really persisted and got worse and worse and worse. And I think she became septic. She had an 11-centimeter urachus in there that was filled with staphylococcus. I mean, she was septic after having that baby, and it wasn't from a bladder infection. She had a urachal remnant. Basically, the entire urachus was there and was now massively infected. Zara says, can I order stuff from the ICN shop to the UK? We just opened up a bunch of countries in our shop that we had shut down. But we are unable to ship natural approach to nutrition products anywhere but Canada, Australia, and New Zealand. And so, Zara, try, but then pop me an email, icnetwork@mac.com, and let me know what you want to order. And I can tell you, because we want anybody out there in any part of the world to become a member and to get our documents and our books and things like that. The dicey issue to ship is always going to be supplements and consumables. Some countries don't take them. The European Union doesn't like supplements. So we're just doing our best. So you can email me, icnetwork@mac.com. That's short for Macintosh Computer. So M as in Mary, A as in Apple, C as in Charlie.com. And I can research that for you. So we can send Sister Protec, but we can't send any of the natural approach to nutrition products to Europe or to the UK. I do have an Amazon.com UK page with some products available in the United Kingdom that you can order from your Amazon shop there that are similar, though. And if you go over to the IC Network shop and you go to the very bottom of it, you'll see a reference to it. And I just found yet another product. What was it? There's a new product. What was that? Sister Q was available in Canada, but that company went out of business. But there might have been something similar for the UK. Anyway, I try to add it to our UK Amazon shop, just to give you a heads up on what you might be able to try there. How you feeling? Anybody flaring today? My sinuses are flaring today. Allergies are ridiculous right now. I'm so tired of being congested. So incredibly tired. I did send out our Biggie newsletter on Friday night. And we did formally launch our IC Masterclass. That's very exciting. And so these are a series of 40 videos that we filmed on all aspects of IC. They're short form videos, usually under 5 minutes, because that's what people want now. They want short form video. And so I've got our first 15 episodes up there, 16 or so. I've got more to come. One's already done. I just have to upload it. So I've got a lot more to do. It's just been a very, very busy time. Busy time for me personally. Jennifer said, love, love, love the masterclass videos. They're amazing. Yay! Please share them. You know, the reason why well, number one, I've been wanting to do the videos for a couple of years now because it became very, very crystal clear that people do not want to go to websites so much anymore. They want video, and I like doing video, and so. But I was just caring for my elderly parents, and that just took all of my time. And so I've had them planned out. They're right there on this big poster of all the videos that I was filming. I just couldn't do them as frequently as I needed to because basically my parents were, at the end of their life and required constant care. Many of you saw them because they would come in and say hi. My dad was 100, my mom was 94, and I lost them both a year ago. A year less a week ago. My dad died on May 12th last year, my mom on May 17th. And I didn't film a video on that because I was too upset and emotional, but I actually might do that. I think that you're a different person after you go through grief like that. You're just I'm not the Jill I was before that. I've never been as sad. And I mean, grief is, you're just not prepared for that level of grief. I mean, it is hard. It is like being hit by a train over and over and over again. And just at the most random moments, you just cry. It's just, you feel this, what do they say? Grief is love that can't be expressed. And I dedicated the last 15 years to caring for my parents. I have no regrets. I'm very, very happy that I cared for them, but I did not, you think you're prepared, but you're not prepared to watch your father take his last breath, which I did. And you're not prepared to hold a cold hand. You're just not prepared. And my mother was just, dad had an unsurvivable heart attack. I mean, he was all there, guys. He was 100 years old. He was all there, both of them. No dementia. We had robust conversations every day. And so in my brain, I didn't see them as at the end of their life. I just didn't. They were so there. They were so present. Dad finally had a heart attack, and he was just like, okay. He loved poetry. He quoted some poem about death, and he's like, I'm good. End of my life, I'm good. And he literally had the most peaceful, sweet, joyful passing you could ever have. I was there. It was amazing. My mom, though, she was like, when we came home, she was more frail. And when we came home and told her that he was not going to survive, that he had at most a day or two, we were like looking at a World War II veteran, a widow. I mean, she was like, Okay, we knew it was going to happen. I just want to be with them. And she seemed fine. And then day number 2, she stopped eating and drinking completely. And we asked her how she was doing. And she said, well, I'm just pretending he's going to come home. And then day number 3, that morning, I was trying to get her up to use the bathroom, and she had grand mal seizure, 3 grand mal seizures in my arm. She went stiff as a board. Take her to the call an ambulance, obviously take her to the hospital, and they called it broken heart syndrome. They said, we see it all the time. You know, she wanted to be with her man. They had just celebrated their 75th New Year's together. And so the blessing here is they spent their last hours together in the same hospital room. But, you know, and that's what you want. That's what you want for them. But you're not prepared. You're just not. You're not prepared. So mom was sneaky because she didn't want us there when she passed. She waited until we were gone. And ironically, I was talking to the doctor who said, hey, she's doing good. She's rallying. And I'm like, great, I'll be down in an hour. And then 5 minutes later, they call and say she's gone. And I'm like, what? You know, I've cried a lot on this video cast in the last year. No shame in the tears. But I want those of you to understand that caregiving is such a blessing. You know, to keep your parents in their homes and to give them the comfort that they need, it's worth it for them. And honestly, it's worth it for you because you will be so freaking proud of yourself for what you did. Don't throw them away in a convalescent hospital. Please don't do that. Please keep them at home as long as you can. Even if you think you can't do it, you might be able to do it. And I think the most painful lesson that I had with them, and this is like the thing I tell everybody, is that the grandparents and the great grandparents are forgotten. They're forgotten by the rest of the family. And it is absolutely heartbreaking to see that they don't get birthday cards. They don't get phone calls. They don't get visits. And I know we all have our own lives, but you have to remember that they sacrificed when you were a baby to help you. And they were there for every one of your birthdays if they could have been. And they may have helped you pay for college, and they may have helped you buy a new car, and they may have helped you buy a new house or help. They may have just tried to help. And it's so amazing how you raise children to let them go and they fly, but you hope and pray that they will remember that they want to be involved. They may be home, they may not be able to walk, they may be in a wheelchair, they may be hard of hearing, but you have to include them. You have to include them. Call them, visit, send cards, send letters, brighten their day, because literally they're sitting at the kitchen table waiting for somebody to recognize how lonely they are. And they're lonely. And 95% of my job was to be there with them and socialize with them. And every holiday was a big holiday, and I decorated and I talked and I played music and we played games. We did all of that. And even if they couldn't decorate the Christmas tree, they watched me decorating the Christmas tree. And so please, please, please include your elders. please remember that they love you and they want to be there with you. And even if they can't be there with you physically, they're with you up here. And so remember that. I believe in heartstrings. You know, we all have these heartstrings. And when they get cut and you lose that, you don't realize how much that heartstring keeps you strong. And that love is a source of nourishment for your soul. And when that's gone, it's such a loss. I mean, I feel them all the time. I know they're here. It's just I don't have that physical connection that was such an important part of my life. Now, interestingly, you would think, we know periods of high stress make IC flare. My IC didn't flare at all. My pain didn't flare at all, which was good. But it was challenging. Erin says, "Hi, Jill, I'm flaring. I asked a question about cholesterol meds earlier. I apologize if I might have missed the answer." No, I didn't see it, hon. You guys talk me down, please, when I go off on these moments, because 1 year anniversary is not easy. So Erin says she started Crestor about a week ago, suddenly getting terrible bladder spasms and bladder pain. Could this med be causing this? Help. The answer is yes. We have had many reports over the years of various cholesterol medications triggering IC flares. And if we, let me, so it's always, and the same with blood pressure medications, although a bit to a lesser extent. So the most common side effects of Crestor: headache, muscle aches and pains, abdominal pain, weakness, and nausea. The question is, what are the other ones? It can cause dark urine. So the other side effects are going to include constipation, headache, stomach ache, nausea, dark urine. You have to wonder why. Why would it cause dark urine? Is that a little bit of blood in the urine? Is Crestor making the the bladder bleed a little bit? I honestly don't know. What does it say? It can happen with patients taking certain statins. A warning signs of rhabdomyolysis. I think that, I'm not sure, isn't that a breakdown of muscle tissue? Let's see here. Yeah, it's when damaged muscle tissue releases proteins and electrolytes into the blood. It's considered a serious medical condition that can be fatal or result in permanent disability. Yikes, these substances can even damage the heart and kidneys. Okay. Muscle pain, loss of appetite, weakness, arthralgia, rash, muscle tenderness, tiredness, diabetes, fast heartbeat, forgetfulness, indigestion, liver problems, sleeplessness, bloating, confusion, cough, depression, general feeling of discomfort or illness. Shivering, nausea. Yeah, hun. You're not the first. I would say that question probably comes up once a month in my office. All righty. Well, any other questions? Any other questions? It says ads will run shortly for some viewers. I am sorry about that. That's just the way it's set up. Jennifer says, I started Crestor before a huge flare that prompted me to get into the urologist. Can Wellbutrin cause a flare? Well, let's look it up. Oh, yikes. Heart arrhythmia, blurred vision, constipation, dizziness, increased sweating, anxiety, confusion, ringing in the ears, trouble sleeping, seizures, stomach pain, decrease in appetite, fainting, irritability, weight loss, restlessness, actions that are out of control, high blood pressure, hyperventilation, nausea, skin reactions. Yeah. Um, a good place to check is the IC Network support forum. So here's somebody else in the Reddit support group 2 years ago who said they did really well with Wellbutrin to treat their depression, but they believe it's flaring them. Yeah, we have a bunch of discussions about it on the IC Network, in the IC Network forum. Johnny says, well, here, hold on. Yama says, I feel pain in the vagina and uterus when I'm urinating. I feel a little bit of relief, feel burning sensation after urination. So Yama, again, where physically is that burning? Is it on the skin on the outside after you've urinated? If it is, that's probably estrogen atrophy. But we won't know. You need a doctor to look at your skin health and you need somebody to check your pelvic floor muscles. I would head on over to a gynecologist since your symptoms are, they feel vaginal and they feel with your uterus. You need to go and have a proper examination with a gynecologist and have them check that out. We need to look at your skin health, we need to check your muscles, and we need to see if there's anything else going on with your uterus. Joni says, I'm looking for suggestions to turn down urethral sensitivity. What supplements might help? So, Joni, urethral sensitivity, I have a really good article on our website. It's called The 7 Causes of Urethral Burning. And generally, what we're going to look for, the 7 causes. Number one, we're going to look for chemical irritation. So for example, very common for some people, especially if you're a redhead like I am, to have issues with bubble bath, with bath soap, with shampoo, things like that, or even from wearing a mini pad or wearing a menstrual pad, that the chemicals come off of the pad and irritate the skin in the urethra. If I put on a pair of underwear wash and Tide for many years, I would have burning in my urethra within 5 or 10 minutes. So look for chemical irritation of that skin. The second thing we're going to look for is just the quality and health of that skin, estrogen atrophy. The urethra is kind of the canary in the coal mine when it comes to estrogen. And as estrogen levels drop and that skin starts to get dry, that urethra gets more sensitive. That happened to me when I was 52, and it felt like there was a drop of urine stuck in my urethra that wouldn't come out. My urethra was very, very sensitive. And that turned out to be dryness. And of course, like an idiot, my doctor had given me estrogen cream a year earlier and I didn't use it because honestly, in my brain, I'm 25 years old and I can't possibly have an age-related issue. And it's not quite so much now, but back then that's how I felt. And the doctor explained that the reason why he had given me the estrogen was because he saw the skin around my urethra getting more sensitive. And so I had urethral burning for months. And then when I finally saw him, he goes, are you using your estrogen? I went, no. He goes, use it. And within 2 weeks of using my estrogen, my skin improved much dramatically. And And as long as I use that little bit of estrogen cream right at the entrance to my urethra, I'm good. So that's something else you want to look at. No supplement is ever going to replace the role of estrogen. That when you give that skin that little bit of estrogen, it produces that mucus and it solves that dryness issue. Um, um, One of the things that you could use potentially externally is something like V Magic, Vulva Balm, which I have right here. So if you're feeling sensitivity on your skin on the outside, oh my God, I never turned my light on. Yikes, sorry about that, guys. So Vulva Balm, very popular with women who struggle with dryness down there. Also the brand name V Magic. And what's cool about it is that it is literally almost the exact consistency of your normal mucus, and it feels really good. That skin down there is supposed to be hydrophobic. It's supposed to push water away. So putting water on it doesn't make it better. The mucus is hydrophobic. So using a little tiny bit of a natural oil-based product, whether it's V Magic or coconut oil, it could be tremendous in just helping to keep that skin as healthy as you can. So this is kind of the supplement version for the skin would be Vulva Balm. And I would look at a couple of different things. Aloe has been found to be soothing to skin. And for some people, it can be soothing to the urethra. I remember we had a little boy who kept telling his mom, my pee-pee hurts, my pee-pee hurts. And the doctor couldn't figure it out. And she finally gave him George's aloe drink, just a little bit of it, and it calmed it down right away. And so there are some aloe products that might be a little bit soothing. Of course, aloe also can be irritating to the gut and can cause some nausea. The aloe that we have is Aloe Path, which I like. I think that's I feel like it's the most effective aloe product on the market because it combines aloe with PEA, which calms nerves down. So you get two beneficial effects from Aloe Path. That's kind of, I mean, come on over and read the blog. Just go over to the icnetwork.org and read it, and it'll go over the other potential causes too. But ultimately, in the end, just remember that urethral sensitivity is usually being driven by dry skin, and no supplement's going to do what a simple estrogen cream will do in improving that. Sometimes urethral sensitivity is from very, very tight pelvic floor muscles. Sometimes rectal sensitivity is from very, very tight pelvic floor muscles. Now, I'm pelvic floor driven and central nervous system driven. Those are my phenotypes. But I now recognize that what I thought for years was rectal pain was actually deep muscle pain or near my rectum. And so sometimes very, very tight muscles can cause burning right down there. So that's something to look for. Also, are your symptoms positional in nature? Does your urethra get worse when you sit down? Does it get better when you stand up? If that's the case, that's again pointing us to muscles and pointing us to muscle squeezing nerves that could be affecting your urethra. So it's not quite that simple. We have to be more comprehensive than just think a supplement would turn off urethral pain. It's really going to be skin health, muscle health, stuff like that. Lori said, what are some pelvic exercises without the wand? I'm so glad you asked that, because if you go over to the IC Network website, in our free download area, there are 2 pages of pelvic floor exercises you can do at home. You just print it out. And I don't believe that I can share my screen. You know what? Hold on. Let me see if I can do this. I've been using broadcast software. Oh, I can. Oh, cool. Okay, so hold on a sec. Let me I should have known that. I don't know why I didn't know that, but I didn't know that. So give me a quick moment here and let me set up a window here and we can do that. Okay. So we're going to, let's see. I've never done it this way before. No, no, I don't want to do a Chrome chat. Yeah, we're going to do that one. Okay, we'll see. Okay, so this is the front page of the IC Network website with our spring picture up. So a couple of things. So if you go to our IC Information Center, which is where you can get what is IC, what are the phenotypes, causes, symptoms, lots of treatment information, etc. All the way down at the bottom, we have our free download area. And there you go right there. That's a PDF file. You just click on it. There's your PDF. Just print it out. And so we've got the mountain pose. Happy Baby, which is a huge favorite of mine. I love Happy Baby. The cobbler pose. It's amazing, when you sit for a long period of time, it's amazing how your thighs start to get very, very tight. So the cobbler pose right here, the pelvic floor squat stretch known as the prayer pose directly relaxes your pelvic floor. This can and should be done against a wall for stability. Anyway, so good ones there. The forward bend, although that's a little bit hard when you've got SI issues. Warrior, can't go wrong with warrior. Love that one. Cobra pose. Okay, so anyway, you can find all of these right over on the IC Network website in our free download area. So we've got that. We've got our Elmer on eye disease fact sheet. We've got several fact sheets that you can print out if you need to educate somebody about it. We've got an old booklet, hasn't been updated, with our phenotypes, and some important articles and treatment charts, and of course our food list, which we're in the process of doing right now. This is really cool. This is our medical records kit. This is like literally one of the first things I made 25 years ago. Because, we all get so incredibly scattered and we're not keeping really good records. And it's really important, especially if you're seeing multiple doctors, that you have all your IC information in one place. And so in this, we have a medical care directory where you can write down your insurance company, your ID numbers, who your urologists are, et cetera, make it super easy, who your pelvic floor therapist is, along with doctors you no longer see, because sometimes you forget their names, but sometimes their name might be important. This is really important here too, diagnostic and testing history. Every time you have a diagnostic test, you want to write it down and you want to write down the results because you want to remember the results. So beginning with what year did you first have your symptoms? What were those original symptoms? And then list every test you've had. And you can print this out and photocopy them and put them in binders. Because it's amazing the number of patients I talk to who they'll go, oh yeah, they tested that. And I go, what were the results? They go, I don't know. It's like, come on guys, you gotta know, you gotta do records. So we got 2 pages of that. You can obviously photocopy more, or 3 pages of that. Holy moly. Why did I do so many? Because how many times do you have a UTI culture? A dozen. Your treatment history, write down the treatments that you try. And one of the things that I think is really important when a doctor suggests something, you need to know, how is it supposed to help you? Like, you don't just say, hey, you shouldn't just accept a medication without knowing what it's supposed to do. So write down, how is it supposed to help? Is it for your bladder wall? Is it to calm your nerves down? A lot of people, for example, think that Elavil is a pain med. It's not a pain med. You don't take it like a pain medication. If you do, you're going to overdose. Elavil is a low-dose antidepressant that you take once a day. You don't take more. So anyway, you want to write down the name of the treatment, how is it supposed to help, the recommended dosage, how long should you wait to see results? What are the potential side effects? And who prescribed it for you? What were the results? Why did you stop the treatment? And what were your side effects? This is important information. And then your pelvic floor therapy log. And what exercises did they give you at home? What would they like you to do? And how many times should you do them every day? And your support directory. Of course, we don't really have local support groups anymore, but who are your IC buddies that you can reach out to? And of course, emergency care instructions. Because here's the challenge. There's going to come a time and place when you're not going to be able to speak for yourself. What if you're in a car accident and you're in a coma or whatever? Don't you want people to know? So, for example, are you sensitive to catheters? You can put down here, hey, if you're going to do a catheter, use a small catheter. I'm really sensitive to it. So, what are your instructions for your emergency medical care team? What would you like your representative to communicate to the hospital or the emergency personnel? And then, of course, doing a voiding diary. We give you an opportunity to do a voiding diary. We also give you some pain levels. Pain scales are really interesting because if I were to ask you to rate your pain on a scale of 1 to 10, how would you rate it? Well, almost all of you would say 9 or 10. But that's not real. This pain scale is something that I developed 25 years ago, and it's actually been used in some research. So level 1, I feel no symptoms. I can do anything. Level 2, I feel slight discomfort, possibly beginning of the flare, but I can still do anything. Level 3, I feel mild symptoms, but it's not stopping me from my daily life, but I'm feeling some discomfort. Level 4, I feel moderate symptoms of IC. I have moderate need to urinate, moderate level of pain. I'm limiting my activity. My frequency is higher. I'm now looking for restrooms and using them. At this point, I'm on my way home to rest and begin my pain management strategies or use pain meds. Level 5, I'm very uncomfortable. I'm biting my lip. I'm holding my belly. I'm usually laying in a bed or a recliner. Walking is more painful. IC has limited me from doing my daily functions. I'm utilizing some pain management meds and tools. Level 6, I'm worried and ready to call my doctor for advice. Level 7, I'm in bed in severe pain. I'm using all of my pain strategies. I may need help. Level 8 is I've called my doctor and I'm going to the emergency room. Level 8 is I may go to the emergency room for help. Level 9 is I'm on my way to the emergency room or doctor's office because I need help managing my pain. And level 10 is I'm in excruciating pain and I'm at the hospital. So you can do a voiding diary here too. So anyway, we have a lot of free stuff along with a lot of great content. But here's the exciting thing. This is our new master class. And so it's at the top of the IC Network page. It says IC 101 Master Class. And I've got about 30, 40 videos filmed, and we're just in production now. And so you can now watch these. They've been up for about 2 weeks now. And I'm really excited because I really think that this is the future of care. I really do. And of how we're going to be working with patients mostly on video now. All right. So, and I'm happy to show you guys some videos if you want. So here, hold on a sec. Hold on a sec here. Thank you, Aaron. Thank you very much for your condolences. I appreciate it. By the way, guys, I really need you all to say a prayer for Donna. IC and Donna, for those of you old timers, Donna has been working with the IC Network for over 20 years now, and she ran our support forum for many, many years. And she still does, but she's in her 80s, and she has cancer, and she's in the hospital right now. So we want to send a lot of prayers her way because she's a love bug. She's helped thousands and thousands and thousands of patients over the years. She's the sweetest person you'll ever meet, just not a mean bone in her body. And she worked so hard to help patients who were in need. by running our forum while I was out doing other things like going to conferences and writing. Jennifer says, can topical estrogen help with the gag layer, or does it have to be an estrogen suppository? Either or, whatever works for you. The advantage of the topical estrogen cream is you can put it anywhere. And so to be able to put a little bit at the entrance to your urethra, if you're having urethral pains, well, some of it also goes in your vagina or vice versa, that I personally prefer a cream like that. Jenny said, I sneezed while going to the bathroom, caused the burning to come back. Well, isn't that interesting? So you sneezed and it caused burning. So interesting. That's very interesting. I don't know. Is it because you tightened a muscle? I know that if I'm going to sneeze, I usually do a little kegel because I'm a little bit older. My muscles are a little bit weaker. And if I have a super, super hard sneeze, you're always worried about a little drop. So I have to wonder if maybe you tighten your muscles and that kind of caused the burning. That's my guess. You know what? Let's just for fun, you guys want to see a video? What can we do? Let's do the pelvic floor video.
You've been through your.
All right. Well, it would help if I turn the sound on. Wait, where's the sound? You know what? I might not be able to do that. Well, let's not do that. You guys will have to try it on yours. The sound is up, but because I'm sharing the screen, I don't know if you can hear it or not. Because it's going into my microphone. Okay, well, we're not going to do that. Sorry about that. Let me unshare my screen. If I can figure. Okay, stop sharing. It's very cool. All right. Any other questions? Any other questions that I can help you with? If not, then I will see you again in probably 2 weeks. If you find these meetings helpful, make sure you come on over to the IC Network and sign up to get our free newsletter. Oh, that's what I didn't show you. Guys, wait. Hold on a sec. Hold on a sec. I got it. Here, wait. Let me go. Wait. This is what you need to see. I want you to see what our newsletter looks like because let me tell you, my friends, I work hard on these. And I hadn't sent a newsletter out in 4 months. Is that it? Let's see. Here it is. Okay, so wait, I just have to log in so you can see it. Okay, no, wrong software. Hold on. I have to do it here. So hold on. Thank you for your patience. Oh, come on, guys. You're going to force me to copy it. Hold on. And preview. There we go. All right, so hold on one more moment so that you can see this. Okay, so if you ever wanted to see what our newsletter looks like, my goal is always to give you useful information, and so this newsletter talked first about our master class and gave descriptions for all the videos that we put up so far. We always feature our latest blogs. So here's the blog on the urachal cyst. This is very exciting. We have a brand new antibiotic approved for uncomplicated UTIs. I hope you understand how incredibly huge this is, because so many infections are now drug resistant. So to bring on a brand new antibiotic that has the potential of killing drug-resistant infections, which there's some research that's showing that is very, very exciting. So that's called PFD. We have a little thing on IC and IBS. It's a fabulous article on great gifts for Mother's Day for moms with IC, written by Stacy, who writes for us. Our current clinical trials. Any chance you have to participate in a clinical trial, you definitely want to look into it, because these are the latest treatments and or new pain methods, pain control methods. This lower one, this yellow and green one, is for a new pain method that's a foam. Very exciting. We have our latest diet articles. Did you know that eggs are naturally acid reducers? The eggs are great, as long as you haven't had your gallbladder removed like I have. I cannot eat eggs right now. We always have links to our latest support group meetings, any other new news we have, like this is our new website on GSM, our latest magazine, and of course, new announcements in our shop. We have new chair cushions called Sun Cloud. We have a new vulva wash from Medicine Mama. Of course, we have the top supplements in our books and things like that. So I'm never abusive with our emails. Obviously, I hadn't sent out one in 4 months. I usually try to do it every month. And it's just the latest news. I don't send out spam. I try not to send out spam to anybody. So anyway, well, I think we'll call it here. It's 3:30. Oh, I ate something which messed up my guts yesterday so badly. I was in the bathroom for hours, and I think it was these new crackers that I bought. Either new crackers or it was some fruit that was contaminated, but I was definitely food poisoning. So I'm a little drained and a little out of it. So I'm going to let you guys go. Be well. Have a great one. As always, if you have any questions about IC, don't hesitate to reach over to us. Come on over to our website, icnetwork.org. You can pop me an email, icnetwork@mac.com. All right, guys. I'll see you later. Have a good one. Bye-bye.